Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.
Good afternoon. My name is John Langell. I'm the president of Northeast Ohio Medical University, and it is my honor to bring you today's VITALS. VITALS is an open format to discuss our nation's and the world's biggest healthcare problems and to hear from leaders who are using the VITALS tools to solve those problems. VITALS tools include value, innovation, technology, advocacy, leadership, and service. Today, I'm pleased to be able to bring you Dr. Bernhard Fassl. Dr. Fassl is a graduate of the University of Vienna Medical School. He went on to be dual boarded in both family medicine and pediatrics, and he has been a global leader in improving healthcare for populations across the world. Dr. Fassl is a leader in several maternal health and child projects in India, Nepal, and Tibet, and other sites around the world, focusing on reducing inequities in healthcare and providing improvements in quality in healthcare on a global scale through frugal innovation and quality improvement projects. He's formerly the executive director of the Center for Medical Innovation at the University of Utah, where he helped with the development of new technologies, including digital health, medical devices, and implementation of quality improvement projects on a global scale. As part of that, he also helped open up a new center for global innovation on the campus in South Korea. His team operates fully funded programs in India, Nepal, Kenya, and Ghana, and serves as an advisor in Rwanda and in other parts of Africa. He is part of a partnership in Nepal and in India with the Karan C. Patel Medical College and Research Institution, helping poor nations with improvement in healthcare. He joined Northeast Ohio Medical University in January of 2020, where he is serving as the director of the Center for Global Health Innovation, and he is leading the global health initiatives at Northeast Ohio Medical University, improving the healthcare for those across the globe and engaging our students and our faculty in those endeavors through public and private partnerships. Without further ado, Dr. Fassl, the stage is yours.
Thank you so much, John. Welcome everybody to VITALS. Let me share my screen and my presentation with you. So I'll be speaking today about new strategies to reducing healthcare disparities. Disparities take many shapes and forms. If you're born in sub-Saharan Africa, for example, you may only live 54 years. If you're born in Western Europe or in Japan, your life expectancy may be as high as 86 years. We don't even need to look very far. Even in our own country, life expectancy ranges from the mid-60s to the mid-80s, depending in which county you reside. But these are just statistics. Discrepancies in healthcare and disparity is really best experienced on the patient level. So let me show with you the reality of childbirth. And these are two deliveries I personally witnessed, one in the Navajo Nation in Utah, the other one in Gujarat in India. Both deliveries feature a baby boy. The weight was just slightly less than 3 pounds. When mom went into labor at home, was rushed to the hospital. The baby was born in the emergency room, did not breathe well after birth. The staff was overwhelmed, lacked skills, doctor was not on site. They had to call him in. They couldn't find the right equipment. They used the adult crash cart, but really couldn't bring the baby back. And ultimately, the baby was referred on an ambulance and died in transport. So the way we normally deal with a situation like this is we convene a panel, we do an audit. And if you look at that case, we say classic case of mismanagement. You have a case of legal liability and so on. So the way we really approach an outcome like this is by asking the question of, well, who did something wrong? Who is there to blame? Who messed up? The other approach that we frequently take is, well, let's invest. Let's just get the best of what medicine has to offer. Maybe we need to get a better X-ray or better trained professionals, a faster lab, or more sophisticated resuscitation equipment. If we make an investment, we surely get something better. We have to, we're spending money. Well, here's the reality. If you are an African-American infant born in Cuyahoga County, within a few miles of tertiary care hospitals that are well-equipped, well-staffed, basically have the highest technology there is, your risk of death, your infant mortality rate is comparable to a baby born in Panama or Syria, which rank number 94 and 95 in the world. What we have done is we have added cost, but not necessarily value. And that's reflected in national healthcare expenditure statistics that show that the per capita expenses far outpace the consumer price index increase. But at what result? The US continues to rank last in the measure of healthcare access and quality when compared to countries with similar economies. So let's question where we are coming from. Let's question our own baseline assumption, which is simply incorrect. Is that as we have the best individual parts of the healthcare system, we have the best universities in the world, the best training programs, the best equipment, and I mean, the entire world comes to the US to learn. We assume that because we have the best parts, we gotta have the best system. Let me give you an example of why that logic doesn't quite work. Let's say you want to build the best car in the world. So you assemble a team of engineers around you that go out and research who makes the best engine, the best brakes, the best transmission. So those engineers come back to you and say, oh, the best motor is made by Toyota, the best brakes by BMW, the best transmission by Jaguar, and so on. So you procure and get those best parts that there are, bring them back together, and then you ask your engineers to build the best car, because clearly you got to have the best car because you have the best parts. So what are you going to get? You're not even going to get a car, let alone a car that drives. It's because system performance and a car that has parts is a system. Our body is a system, is not a sum of the quality of the individual parts. System performance is determined by how well those individual parts interact or work with each other. And so I just want to emphasize the word interact, because this is going to guide us through the second part of my presentation. Let's take another look at these two cases and really look at what actually happened, but this time applying a systems thinking approach. Instead of asking who did something wrong, we ask now the question, why did it happen? What are the circumstances that lead to that bad outcome? And how was it possible that those safeguard measures that are in place were bypassed? So what we're essentially doing is a health system autopsy where we focus on the process. And all of a sudden, this relatively simple medical case of birth asphyxia got a lot more complicated, because we now have information that actually mom lives in poverty in a shelter. She's malnourished, underweight, father is unknown, she didn't have prenatal care. So maybe the conclusion is this is a community or public health problem, or maybe it's a staff and infrastructure problem, or a case management problem, skill problem, an equipment problem, a logistics problem. There's so many options of where this is a problem. But the reality is that we look at a health system that has different domains or parts, the staff, the skill, equipment, the patient environment, the data systems, and so on. But what happened is that all these parts as a system are not performing well and resulted in a poor outcome. The airline industry figured out that process analysis and systems-based thinking is their preferred method to ensure safety. They did this in the 1980s when flying was still quite unsafe. In the manufacturing business and industry, process-based analysis and improvement is the standard since the 50s and 60s, starting in Japan. So let me introduce two people to you who really coined the term process management and systems thinking. W. Edward Deming is an engineer, philosopher, and business theorist who published the production standards for the US Army in World War II. So he introduced statistical process control techniques to workers engaged in wartime production. One of his famous quotes was, "Experience means nothing unless you understand the process." The second person is Russell Ackoff. He's an American organizational theorist and a true pioneer in the field of operations research, systems thinking, and management science. And he was really the first person who was able to describe the interactions between organizations, systems, and human behavior. Deming is most known for the Deming cycle, or what's now known as the PDSA cycle, where he uses continuous study and improvement for process management. His approach essentially ended the era of the machine age, which was the hallmark of the Industrial Revolution, where people were just cogs in a big machine. And he refocused the operational analysis on process management. This was implemented during World War II by the US Navy and by the US Army, who needed to produce war materials. Henry Kaiser won a contract for the government and started to produce warships at the Kaiser shipyards in Oakland, California. And I'm going to come back to Henry Kaiser a little bit later again. But using Deming's management technique of process management, the US was able to outperform the Axis powers by 10-1 with regards to warships and armored vehicles by 1943. Another famous quote that Deming had was, "In God we trust, all others must bring data." But the way he used data was unique and very different. It was not the traditional quality assurance method of maintaining your quality, where you identify the bad apples, you identify those that practice outside the scope of what we deem acceptable. By eliminating those, you do shift the quality curve to the left, but not very much. He decided to use the data to slim up the bell curve, to set the limits within which people have to practice, also practice medicine, through reducing variation. Instead of providing quality assurance, you can move the quality curve to the left, significantly more effective. So why is process management such a challenge in medicine? The airline industry uses it since the 1980s. It's because of how we are brought up. We are brought up as craftsmen. Medicine is a craft. We are doctors, we are healers. All that matters is the patient-physician relationship. We are smart, we study hard, we work hard, we don't even need to sleep. And we love to sacrifice ourselves. And so the way we all grew up is if we just work hard enough, we can do it all. We can be the best doctors. And those who aren't, who make a mistake, they just didn't try hard enough. They need to work harder. So by introducing process management, rather having it be about a person, we actually cause an identity crisis for the doctors. We continue to teach medicine as a craft, that the doctor-patient relationship is basically all that matters, that my own knowledge and skill is equal to the healing that I have. We continue to train people as linear thinkers, cause and effect. There's a symptom, there's a diagnosis that goes with the symptom, and then a treatment. It's that simple. The problem is, it's not that simple, because we fail to understand the context of health and disease. We fail to understand the circumstances, social circumstances, economic circumstances, everything that's non-medical that has a huge impact on health. So this is what complex adaptive systems thinking embodies. The fact that the healthcare delivery system is made up of thousands of processes that are linked, aligned. We have patients that have multiple interacting problems, not isolated problems of the heart or the liver or the lung. Our systems, our organisms are inherently dynamic and subject to human behaviors. For us in academics, process management and quality improvement is in direct conflict with our pursuit of academic perfection. Here's the reason. Quality improvement works following. You are at some kind of baseline performance level, and then you apply PDSA cycles. So your definition in quality improvement of success is, let's make progress, right? Today is better than yesterday. Tomorrow is going to be better than today. That's success. So we have improvement over time. But that's not how we work in academics. We search for the ultimate truth. It's the 95% confidence interval. We are either above or below. It's significant or can be discarded. So success is a predefined outcome. It's black or white. So the idea of quality improvement and process management is in direct conflict with our pursuit of academic perfection. So where do we go from here? What's the future of healthcare and education? Well, the future is to create systems thinkers, and along with it, creating a new identity for doctors to meet today's challenges. And that new identity has to evolve around the concept of creating value in healthcare. Now let me go back to Henry Kaiser, because the Kaiser shipyards didn't only produce ships, they also founded Kaiser Permanente healthcare system, and it was founded on the same process management principles as a shipyard. The way Kaiser Permanente to this day defines value in healthcare is quality over cost multiplied by the patient experience. And so the addition of patient experience is critical because it contains dignity of healthcare, equity, accessibility, and respect. With that, I wanted to point out that the future is not a dark future for physicians. It's full of opportunity. It's full of opportunity for innovation that continues to happen along the similar lines of medical devices, digital healthcare, health systems. However, the ultimate goal of innovation has to be to improve systems performance and not necessarily only the quality or the performance of a part. With that, I want to conclude my presentation. Thank you for inviting me to have you speak to you today. I would like to introduce Monica Robbins from WKYC. She's our senior health correspondent.
Thank you, Dr. Fassl, and welcome to our 73 participants. If anyone has a question, feel free to put it in the Q&A and I will be happy to ask. Dr. Fassl, we already have one question. Your approach aligns well with appreciative inquiry. Have you ever considered working with organizational behavior experts to accelerate this approach with health systems?
I would love to work with organizational experts because this fills a huge gap in the way we not only train the future workforce, but also the way we operate our own systems within a university or within a hospital. So I think that addition to the medical side would be more than welcome.
How difficult would it be for Americans to culturally adapt to a concept that may be more easily applied in developing nations?
I don't think there's adaptation that's necessary. I think it's shaping the expectation of what the goal has to be. And if you look at medicine in general, in the way it's operated in the United States, it's a business, but not a service. Because it's a business, it needs to primarily make money and service is secondary. I think it requires rethinking of the ultimate goal of what medicine is. And once we can embrace the different approach to medicine, I think the alignment between low resource or high resource countries is an automatic.
Can you provide a tangible example from your own work where you applied process improvement globally and explain the impact that it had?
Yeah, there are many examples. I mean, this is sort of how I operate in general. So the first step, and probably the most important step, is before you even start thinking about a process change, you got to understand the process and the environment in which the process takes place. So immersion, participation, observation, that's not judgmental, but just that takes information in, is the critical first step. So an example is the birth asphyxia case that I showed you is from India. There are many of those cases that we witnessed. And so over time, as we came to understand how the Indian healthcare system works, not only on a medical level, but also how cultural ramifications like the caste system in India, how the economic discrepancies in India influence care seeking, access of available services, we were able to actually analyze a workflow and redesign a workflow for our patients that provided equitable access to the health services that were offered by the government in our partner hospital. So over time, we were able to achieve compliance with the key quality metrics that apply to delivery rooms. And after hospital discharge, we were able to develop a system with the government that allowed for health surveillance of high-risk infants that reduced the mortality of low birth weight infants from 20% at baseline to now 1.5% consecutively for the last 5 years.
This is from one of our participants. Thank you for sharing your perspective, especially on the quality and systems alignment. I've always found and teach a strong correlation between the scientific method, quality improvement, and innovation. This helps support the fact that clinicians are well positioned for innovating. What is your perspective?
Yes, physicians are well positioned for innovating. However, in medicine, we make the mistake that we always look for medical solutions for medical problems. And I think physicians alone might be able to generate an idea, but we are really unable to develop the best solution possible because we limit ourselves by only including medical team members. I think what we physicians need to be a lot better about is including non-medical team members, the engineers, the social scientists, anthropologists. There's so many people who have a lot of insight to offer of how systems work and how they would approach it. And I think the future is to build multidisciplinary teams that expand from medicine outward.
In a healthcare system so complicated as ours, influenced by insurance frameworks and a capitalist mindset, where would you begin efforts to affect change?
I think as you phrase the question, you already have the answer built in. It's the capitalistic framework that medicine is a business. I think by regarding medicine as a business that's meant to be profit-making, it's a sick care business. You only make profit if you keep people sick. It's not a healthcare system, it's a sick care system. So I think our mind of what healthcare actually is and what is incentivized or not incentivized needs to be completely reframed to make it into a healthcare system rather than a sick care system.
If you were tasked with solving infant mortality in Cuyahoga County, walk us through your very first steps and what resources would you take? And are you teaching this to medical students now? And if not, where in the curriculum would you place it?
Wow, these are 3 questions in one. let me get to those one by one. So how would I approach it in Cuyahoga County? Well, there is a very good heat map of Cuyahoga County where infant mortality rates are average, below average, or way above average. I think very few of us really understand the process that patients who live in low resource areas with high baseline infant mortality have to go through. So the first thing is we need to make an honest attempt and get in their shoes and walk their walk and understand where they live, how they live, what the barriers are. So that's step number 1. We got to understand the system. We got to understand the process. There's obvious, each problem has already a built-in solution. So then, by building trust and a connection to the community, it's probably not even us who has to decide what process changes need to take place. The people already know. They just need a medium to communicate it to us. So I think by building a collaborative program that includes our patients at the very forefront, those who never have a voice, the poorest of them, the ones that are in India, they would be untouchables, right? We ask them, what do you think would make it better? I'll tell you. We just have to listen and give them a medium to communicate. So with that, you already have your strategy of implementation. And then what's required is somebody who is willing to make an investment in health rather than treating the sick. Second question is, how would you teach it? Immersion. So you cannot teach how barriers to access or parents who live in patients who live in poverty, what they experience, unless you try to live it with them, even if it's just for a week or 2 or 3. I'm a very strong believer in experience and getting yourself into the shoes of the population who you try to serve. So you learn by being there. The teachers, it's like ridiculous that I'm dressed in a suit that I would teach someone about disparity. I think the people who live in poverty have to be able to teach you. So I am a strong believer for immersion. Where in the curriculum would I place it? Well, this is the home of global and underserved health. And I think that students should be required to complete basic coursework, or even better, complete the required immersion so they can see and feel for themselves.
With so many undersourced countries, how do you determine the countries that you choose to work with?
Partnerships. So too often, medical mission trips serve the purpose of the donor. But donor-driven interventions create inherent inequality and create a system of dependence and subordination. If you have a local partner who has heart, guts, and determination, they can communicate to you the needs and probably even the solutions. And if we listen right and provide the right structure within which problems can be analyzed, prioritized, we can also develop a structure to solve them. So partnerships and having the right partners on the ground is the single most important key ingredient.
Dr. Beach asks, recent studies suggest the benefit of the social determinants of health on medical outcomes. What are your thoughts?
Oh, I agree 100%. Social determinants need to be understood and applied. So this is what I was going after with my slide, that we train linear thinkers of symptom diagnosis and treatment, but we fail to understand the circumstances where whether someone takes a medication, how they perceive a disease or a treatment is highly influenced by the cultural, the ethnic, the economic background. And so I think that social determinants of health have both an effect of how you diagnose and how you treat patients. And I think it should be part of our baseline evaluation.
Is the answer to this going back to house calls?
Yeah, one of the answers, right? I mean, there is good reason why general practitioners exist. We replace them with all specialists, right? A GP, especially in an urban area, doesn't really have much of a role besides sending people somewhere. But I think a general practitioner as a medical home is probably the most cost-effective method of doing it. And so I'm biased. I'm from Austria originally, where 80% of healthcare is delivered by general practitioners. And so where I trained initially, the general practitioner had actually a coffee and cookie station in his office, where all the people in the village who didn't have anyone to talk to, they would show up every day for coffee and cookies. And so they have the social circle. And so the doctor was their social networking area. There was nobody sitting at home alone being depressed. They all came together. And it's a lovely concept I would really like to recreate somehow.
How can we incorporate into undergraduate medical education practices that will help promote our students' systems thinking?
So not just for undergraduate, but also graduate programs, there is a huge discrepancy between what people are tested on and what people actually really need to learn in order to do the best job they can once they're released into society to make a contribution. So the primary function of an education system is, unfortunately, to get students to graduate and pass whatever exam there is, the license, the quality assurance approach, right? You gotta pass that bar and get over it. So systems thinking isn't gonna help you get a good score, I fear. It's gonna make you, for sure, a much better doctor. And I think unless we can really address that particular problem of what's important to graduate versus what's important to be the best professional you can be, we're going to have a problem.
We already know that at least 80% of outcomes in the US are due to social determinants of health. Perhaps the biggest barrier is getting those in power to do something about it. How would you convince those in powers to embrace your approach?
Immerse them. Our world, let's say the affluent world, is full of judgment and not necessarily full of wisdom. I think we have our own ideas, our own perception of truth, without really ever having stepped into the world of those who are less fortunate. You may think what you want about Bill Gates, but he's actually making a good effort to try and stay in touch with the very front line of healthcare. And I would encourage all politicians, all policymakers to not be in an air-conditioned room drafting a policy that nobody can follow. I encourage you can draft a policy, but first you got to come to India with me, live in India for a month where it's 118 degrees, you don't have AC, and I make you go to the field with the health workers who care for the untouchables. And I'm 100% sure that your policy will look completely different from what you had in mind.
How can you leverage big data and AI to accelerate sending the root cause and develop solutions? And do we currently have access to that data or comprehensive data on these patients?
We don't have access yet. However, it's up and coming, and the power of data is reaching low resource environments as well. So I'm very fortunate to work with a digital healthcare. They are a company, but also have an academic arm in India that is leveraging low-cost data systems in now 43 countries in the world, all low resource, with the goal to identify commonalities and strategies for outcomes monitoring and improvement. So even though this is in its infancy, that same thought has been picked up by very skilled individuals. And I think in the next 10 years, we will see the AI and big data analytics take a quantum leap.
Again, I want to encourage our participants to ask any questions, just put them in the Q&A. So from your perspective then, how do you help the next generation of doctors get the better understanding of the root causes of a disparity when in the big scheme of things, it's not very easy to have immersion? How would you make that happen?
I think immersion right now is considered optional, right? You have to go through an effort to carve out time. Students have to spend their own money. They have to sort of create their own opportunity. I think in the education sector, this shouldn't be optional. It's a key ingredient. And I would not even call it, I mean, you can call it immersion, but I would say understanding. You gotta understand people, their needs at the very root causes. So I think you just build it in. It's like cardiology gets built in. Of course, you're gonna teach about the heart. You should, but it shouldn't be optional to do immersion.
What are the strategic investments educational institutions and universities should make to reduce health disparity?
If you look at medical students and young physicians who dedicate their life and their career to serving diverse populations, to underserved settings, the common thread, like 69% of them, got inspired by an underserved rotation or additional educational programs at the university that introduced the concept of global or underserved health. So I think those activities should not be considered a fringe idea in your education. But if you really want to build up a workforce that takes on those challenges, you got to integrate it into your curriculum. And data shows that if you do, you get a product.
All right, we have no more questions in our Q&A. So would you like to make some final thoughts before we hand it back to Dr. Langell?
I think I only have one final thought, and it is the ultimate change that I think we all have to go through is the way we perceive disparity, the way we perceive those that live less fortunate lives commonly has the connotation of judgment. It's their own fault. They're lazy, right? I really wish if there's one thing that I could change is replace judgment with understanding. And I think immersion is probably your best way to get there.
Dr. Fassl, thank you so much for your time. Dr. Langell, I will hand it back to you.
Thank you, Monica. Thank you, Monica. And I really want to thank you for your dedication to the VITALS program and your continued expert moderation. Dr. Fassl, thank you for sharing with us the great work you've been doing and your unique approach. We should all be adopting it in healthcare, and we are thrilled that you are part of the NEOMED team, and you're going to help NEOMED be a national leader in this space. For all of you, thank you for your participation. Stay engaged, stay active, and become the leaders of tomorrow for improving healthcare and improving upon healthcare disparities worldwide. Until then, please join us next January on the 12th for VITALS when we reconvene for 2023. Thank you.
Health outcomes. Changes due to interventions. To bring positive change, patient experiences and health must both improve. Healthcare costs must be lowered, and clinician and staff burnout has to end. But our problems are big. 133 million Americans have at least one chronic disease. 500,000 people are dying every year from hospital errors, injuries, and infection. The shortage of primary care professionals will be as much as 100,000 in just the next 5 years. Big problems require bigger solutions. Positive change needs acceleration. It needs to happen now. But these are not so easy solutions that many don't want to hear, and even few are willing to talk about. How to lead such a change? How to discover, discuss, and disrupt healthcare to make a difference now? This is VITALS, Visionary Health Leadership in Action.